apologies for joining on a virtual platform. The topic assigned to me is choosing the right oral agent. As you can see, there are other learned speakers who are going to talk on the virtues of individual agents like 5-glitazone, acarbose, and SUs. And what I'm going to do is do a case-based discussion and set the stage for the subsequent more important talks. The choice of an agent for managing any disease depends on efficacy, safety, the possibility of its use in comorbidities which diabetics have. In relation to diabetes, we are also concerned about any benefit that the comorbidities, specifically atherosclerotic cardiovascular disease, renal impairment, heart failure, and maybe NASH. There is a physician bias because one can use only at the most 3 oral agents before one goes for injectables, though the distinction between injectable GLP-1 analogs is getting a little bit blurred with introduction of the semaglutide oral form. The side effects of the drugs are also very important. There is a guideline support for almost any molecule that we use, but if there is some guideline support, then one is on a stronger footing. Frequency of dosing also decides the drug given the polypharmacy that the diabetics receive. And since many patients have to pay from their pocket for the therapy, affordability of a drug is another issue. The first patient we have is a 65-year male with CAD who underwent CABG in 2016. He's on metformin and a DP4 inhibitor, and HbA1c is 6.9. He has been referred for diabetic management by his son who stayed in the United States, not by the cardiologist. What would you consider in this patient? Possibilities could be that one could continue the same treatment. And since his HbA1c is at 6.9, would you stop one of the agents, maybe DP4s, or add SGLT2 inhibitor, or add a GLP-1 analog, or add acarbose? But the answer to this, of course, there's no single answer, is either you add an SGLT2 inhibitor or you add a GLP-1 analog. At the present moment, evidence exists only for injectables. So oral semaglutide administration would have to wait the results and outcomes of the SOUL trial. This is a picture which I have taken from the 2021 ADHD guidelines, which talks about the administration of metformin with lifestyle changes. But there is a specific column to your extreme left, which says that if somebody has got atherosclerotic cardiovascular disease or is at high risk for the same in view of age more than 55 years, presence of occlusion of peripheral vessels or carotid vessels more than 50%, then one should use either GLP-1 or SGLT2 inhibitors. It also says that patients with heart failure and CKD with proteinuria should get an SGLT2 inhibitor with proven benefit in this population. The second patient is a 32-year male IT professional who is diagnosed diabetic 1 year ago, who has started on oral antihyperglycemic drugs. He wants to take only 1 to 2 tablets per day without risk of hypoglycemia, has gallstone disease. Inherent in this is the fact that he has been possibly on sulfonylureas and had some hypoglycemia. So he is concerned about it, and he has gallstone disease. He was intolerant to metformin. What shall we give for his glycemic control? Shall we give him alpha-glucosidase inhibitors? It will not cause hypoglycemia. And his HbA1c was about 7.6%. It will get him to the target, but it requires multiple dosing. SGLT2 inhibitors can also be given. He's obese and he stands to lose some weight. DP4 inhibitors can also be given. And if oral semaglutide is available, his nephew wants to send some medications which he has searched on the net as oral semaglutide. So we can give any of these, but the ones that are available and which might benefit him are SGLT inhibitors and possibly DP4 inhibitors. But if you have to look at the weight, then SGLT inhibitors are possibly within reach, which he can buy without having to depend on his nephew's intelligence or Google search. This is the same picture highlighting the usage of drugs which do not cause hypoglycemia, in which you have got D4 inhibitors, SGLT inhibitors, and glitazones. Till recently, GLP-1 analogs were available as injectables, but in oral semaglutide, we have the possibility of having that drug as the most potent anti-hyperglycemic drug, which does not cause hypoglycemia and also causes some weight loss. The third patient that we have is a diabetic detected on routine workup with fasting of 176, that's B1C 8.6. What medicines should we give him? Shall we give him metformin monotherapy? Shall we give him dual oral anti-diabetic therapy? Or shall we give him injectables? His HbA1c is of the type and kind that is unlikely to reach the target without causing a dip beyond, let's say, 1 to 1.5%. And in this person, one can use dual oral anti-diabetic therapy. Metformin oral monotherapy alone will not work. The choice of the second agent with metformin, of course, depends on what you want to use. But again, preference is to be given to drugs that do not cause hypoglycemia. Injectables obviously can wait in this patient. And the recommendations of AD also are that if the person's HbA1c is more than a 1 to 1.52 percentage point above the target, one should give initial combination therapy. Then we have this 36 years homemaker who is newly detected diabetic, is coming with an HbA1c 6.4. She asked for a therapy which gives her a lasting benefit because she is sure that she won't be able to have regular follow-ups since she has got 3 kids to look after. What treatment would you like to start it on? Metformin alone, DP4 inhibitors alone, metformin with DP4 inhibitors, or SGLT inhibitors alone. Well, this patient can reach target with almost any therapy, but there was a study done, a verified study, wherein the administration of metformin along with vildagliptin to begin with was found to be better than metformin alone in the initial phase. Of course, when you give 2 drugs versus 1 drug, you will have more failures with the 2 drugs. But the surprising part was that in the second phase, when both these patients, after the failure of metformin in the metformin group, were receiving vildagliptin, the delay in introduction of vildagliptin, so to say, had produced more secondary failures in individuals who received vildagliptin after initial metformin therapy compared to those who were on this therapy to begin with. So there is some suggestion by this verified trial that a combination of a certain D4 inhibitor, in this instance, evidence is there only for vildagliptin, but authors would like to point out that this could also be the case with any other oral anti-hyperglycemic agent that does not cause hyperglycemia, because it gives you confidence to reach lower levels with combination therapy. So this has come also in the guidelines that you could use vildagliptin with metformin to begin with, even when a single agent would do. And the benefit was there in terms of the combination therapy giving good results and no failures for about 50% of patients for a duration little more than 4 years. The 5th patient is a male admitted to ICU with unstable angina detected to have diabetes on routine evaluation with fasting of 145, postprandial of 256, HbA1c of 6.8%. What would you start? Metformin, D4 inhibitor, SGLT inhibitor, or GLP-1 analogs? Well, in the routine practice, most people would start this patient on metformin plus SGLT inhibitors, but there is some evidence, some initial suggestion by the European Society of Cardiology guidelines that in drug-naive people, one could prioritize SGLT inhibitors over metformin. This is debatable, but the reasoning behind this is that metformin's presence in the CV outcome trial was not mandatory for the benefit that was seen with SGLT inhibitors, or for that matter with GLP-1 analogs. Two, if you start with metformin therapy and introduce SGLT inhibitors, given the modest benefits that you have with metformin, you would be delaying the introduction of a more effective agent in GLP-1 analogs or SGLT inhibitors, and you would be adding to the pill burden. So you could give in this patient metformin, of course, but you must alongside that give SGLT inhibitors. Mind you, the HbA1c is not the target here, organ protection is. 70 years female, old home resident, was detected to be diabetic recently, is on metformin 5 mg twice daily, has HbA1c of 7.6%, EGFR is 42, she has normal LFT. What would you like to do? You increase metformin to 1000 mg twice daily? No, because your GFR is 45. Add sitagliptin 100 mg once daily? No, because sitagliptin requires dose modification like vildagliptin as also alogliptin. Add an SGLT inhibitor? Yes, you can add an SGLT inhibitor, but at this GFR, there will be renal protection with drugs like DAPA and CANA, but you may not get the person target HbA1c. The answer could be that you could give a reduced dosage or modified dose of gliptin like vildagliptin, or a gliptin which does not require dosage modification with SGLT inhibitor, the second one being given with the intention of renal protection rather than glycemic control. The guidelines also suggest that people with type 2 diabetes and CKD should receive metformin plus SGLT inhibitors. Metformin should not be given to people whose GFR is less than 30, and above 60 can continue in the dosage that you usually prescribe. 45 to 60 also you can give in the same dosage. 30 to 45 you give half the dose. Below 30 you do not start this dosage. SGLT inhibitors can be given up to GFR of less than 30. And if this does not work out, you could give a GLP-1 analog or a D4 inhibitor or a glitazone or alpha-glucosidase inhibitors. The alpha-glucosidase inhibitors can be given up to GFR of 26. You could also give sulfonylureas and insulin, but these two are going to produce hypoglycemia, and you might reserve their usage to patients who cannot get control with other agents. A bank manager is coming with a new onset diabetes. Fasting plasma glucose is 256, post-prandial glucose is 356, HbA1c is 9.6. He was diagnosed diabetic for evaluation of osmotic symptoms and weight loss of 6 kgs. What would you start? 1 OAD, 2 OADs, 3 OADs, or insulin plus minus OADs? This person is symptomatic. His HbA1c 9.6. Please and please don't give him oral agents. Give him insulin. You might give other agents. And this is a nice diagram from the ACE guidelines, which says that HbA1c more than 9, if person is symptomatic, should be given insulin. If it is asymptomatic, you could try triple drug treatment. So in conclusion, while glycemic control is one aspect of managing diabetes, dyslipidemia, hypertension, and when necessary, smoking cessation, obesity management, antiplatelets are equally sometimes important, the choice of anti-hyperglycemic agent to achieve it has issues beyond mere glycemic control. Patients at risk for or with ASCVD, heart failure, and CKD merit or mandate the use of certain agents like SGLT inhibitors and or GLP-1 analogs, which can be used together. The differentiation being that SGLT inhibitors have got specific role in heart failure and CKD progression with heart endpoint reductions, whereas GLP-1 analogs have got a role only in proteinuria reduction. Avoiding hypoglycemia should be an important concern, and it will aid even better control without fear, and you might reach target HbA1c levels which are unimaginable with drugs that cause hypoglycemia, like sulfonylureas. We have a disease that we diagnose with HbA1c 6.5 and keep the target at 7. And all the inhibitions for this in terms of age, in terms of presence of someone to take care of you, CKD, presence of macrovascular disease, hypoglycemia, etc., just disappear if you remove the hypoglycemia factor. Given the limitations of efficacy, it would be prudent to use more than one agent while initiating therapy when one drug is deemed to be insufficient. Measuring eGFR should be routine rather than exception. Even when one drug can achieve the target, there is evidence that giving combination therapy with a D4 inhibitor and metformin might give greater benefit and reduce the incidence of failures, secondary failures. While metformin is initial therapy, unless contraindicated or not tolerated, there is some noise about dethroning it in the setting of ASCVD as the first-line treatment. There are, of course, instances when you should not think of using oral drugs and insulin should not be withheld. Thank you very much for your patient sharing.